Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you for joining us for another segment. September is Desmoid Tumor Awareness Month, and given that nearly 30 to 40% of desmoid tumors are initially misdiagnosed, it's important to raise awareness among both the patient and the provider communities to better support those who may be living with these rare, devastating tumors. Welcome to Health Professional Radio, Dr. James Cassidy. He's joining us here as Chief Medical Officer at SpringWorks Therapeutics. Thanks for joining us.
Hi, good morning.
Well, as Chief Medical Officer there at SpringWorks, give us a bit of your professional background and talk about your role at SpringWorks.
Yeah, so I'm a trained medical oncologist, was a physician scientist, trained in the United Kingdom, and was a full Professor of Oncology there for many years. And about 11 years ago, changed careers into the pharmaceutical industry. I've held various posts in different companies, increasing seniority, and recently joined SpringWorks as the Chief Medical Officer. Essentially, I run all of the clinical activities of the company, and it's a small biotech company. We have a couple of assets which are in the late stage development and about 13 others which are in clinical development. We're what's called a targeted oncology company. In other words, we're looking at the genetic causes of cancer and then targeting drugs against those genetic causes. And desmoid tumors and our asset, nirogacestat, is our primary number one asset, and we're in phase 3 studies, and we're expecting to have results from them reasonably soon.
Exactly what are desmoid tumors? What do we as listeners need to know about them, and why are they so often misdiagnosed?
So desmoid tumors are rare, which is one thing. About 1,000 to 1,500 patients per year in the United States. They happen in younger people, so the peak incidence is in the 30 to 40 years age, but it can happen at any age, and including in children. They present in various ways, sometimes as a lump, sometimes as pain, sometimes as a disfigurement or functional impairment because of pressure from the tumor. They can occur in the limbs, and they can occur in the body cavities, in the chest or in the abdomen. And because they're rare and because of the age distribution, most physicians will not think of malignancy or a type of cancer in that age group, because cancer is traditionally a tumor of a disease of older people. So these things are misdiagnosed or glossed over, particularly if they're in an abdominal or chest cavity where you can't see a lump. And that's why they're so hard to diagnose. In addition, they're kind of slow growing. So again, it takes a bit of time for people to present and for people and their physicians to realize that there really is a problem. They're often dealt with, first of all, as being some orthopedic injury, or you've somehow damaged a muscle or something that's happened like that, which is causing the pain and a bit of swelling. So that's part of the misdiagnosis. And clearly, the rareness of them doesn't help, because in medical school, medics are trained to deal with common things, and rare things being rare, we have less training in those rare things, and therefore they're not front of mind for physicians as a differential diagnosis, and even more so for patients who are completely unaware that these things even exist.
If they're so very slow growing, is it safe to assume that once they are detectable on imaging or by touch by a physician, that the patient is in some serious trouble? And if left untreated, what should they expect?
So it's very variable. It's very dependent on anatomy, really. If this lump appears somewhere where there's no vital structures around, and it can grow and not press on things and not invade into things which are critical, then they can grow to quite a substantial size. In other instances, they're actually quite small when they present, because they've invaded or pushed against something which is critical to their attention, because they've got symptoms. They're also highly variable in their progression. There is a spontaneous regression rate, which is maybe around 20% of these tumors which will grow and then will get smaller again spontaneously. And that's part of how we treat them nowadays. And in the past, these things were generally surgically excised, and we realized over the years that that's not such a good idea because they tend to recur. Mm-hmm. And when they recur, they often recur in a more aggressive form. They're quicker growing and a bit more invasive than they were in the first place. And so traditionally, that traditional approach is not followed so much anymore.
Is there a genetic component to this rare disease?
There is, yeah. And by genetic, there's a particular syndrome which is called APC, and there's a genetic background to that. There's also a mutational background to the tumours themselves. They have what's called Wnt and Notch pathway mutations, and that's the focus that we have. We have a drug called a gamma secretase inhibitor, which is called nirogacestat. And that blocks the activity of Notch. And so when you look at the cells that are dependent on the Notch pathway, which is the desmoid cells, and they're inhibited by that drug. And that's the drug that we have in clinical trials, in the phase 3 clinical trial right now. Mm-hmm. And we're expecting results by the end of this year. And clearly we're very excited about that because there are no approved therapies for this disease. So this would be the first of its kind, and one would hope that would greatly help patients with this particularly nasty disease.
Do you anticipate a smooth FDA approval process? Is that pretty much expected by the end of the year? And if so, after approval, when do you anticipate it being available to patients?
Well, there's a number of steps in there. First of all, we have to get the results of the study, and they have to be positive. So that's the first step, and clearly we're all fingers crossed and everything else that will be the case. We then have to make an application to the FDA, and they would then either approve or not approve of that. And there's, like every drug approval, there's always little bumps in the way and like that. But, we don't expect any particularly difficult interactions with the FDA. But one can never tell. It really depends on the data we get from the clinical study. Assuming that we get past that and we get approval, then we would expect that the uptake of the drug to be quite large, because although there's between 1,000 and 1,500 new cases per year, that people would live with this disease for a very long time. It's normally not a lethal disease, but very nasty nonetheless because it's locally aggressive. So there's many patients out there who are waiting for some form of therapy. So we would expect the uptake of our drug to be quite large. But again, that is dependent on the clinical results. If this looks like something that's really transformational, then obviously more patients will be interested in it. And that's what we're hoping will be the case.
Well, give us a website where we can learn more about SpringWorks.
The website is www.springworkstx.com.
Well, I appreciate you joining us here on Health Professional Radio this morning and giving us this information. Hopefully we'll have an opportunity to speak again before next September about desmoid tumor awareness.
Thank you, and thanks for having me.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Jim Cassidy. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.